Hello, I am Kyungwon Kim. It's a pleasure to meet you all through this online surgery session. Today's surgical case involves a 68-year-old male patient. In fact, this patient was previously featured in a case involving anterior teeth. The panoramic X-ray in the initial visit, the condition of site number 26, where the tooth is missing. As you can see, there was significant bone loss on the palatal side, and there was very little bone remaining on the extraction socket at the time of the visit. The patient wanted an implant in the 26 and number 27. He already had tooth 26 extracted at another dental clinic about a month ago. As shown in the CT scan earlier, the number 26 site lacked sufficient bone on the palatal side. So I decided to perform a re-curettage on the extraction socket and proceed with socket preservation using A-Oss Collagen. After that, a sinus lift was performed using the OneCAS KIT. For the graft material, A-Oss Collagen was used. Then, implants were placed both on the 26 and number 27 sites. Since only about a month had passed since the extraction of number 26, soft tissue healing was not yet complete. I removed some of the mucosa and thoroughly performed socket preservation using A-Oss Collagen, especially for the palatal bone defect, before suturing. The last image shows the stitch out 9 days later from socket preservation. You can see secondary intention healing is occurring. In this case, we did not use a collagen membrane. However, in more recent cases, a collagen membrane can be used in socket preservation for better results. That can be one of the ways for recent cases. In the number 26 site, which was extracted a month ago, socket preservation was performed using A-Oss Collagen. Due to the significant palatal bone deficiency, extra care was taken to preserve the alveolar ridge through proper socket preservation. The panoramic X-ray was taken about 2 months after socket preservation, and the next image was taken approximately 3.5 months later. At this stage, the cone beam CT shows that while the preserved socket is filling in, the palatal side is still slightly below the desired level. The upper right image is the CT scan before socket preservation, while the lower image shows the condition after 3.5 months. Since site number 27 had already been extracted, it was in a healing ridge state, thus no major issues. As in the surgical report, we planned using OneGuide and OneCAS KIT. The planned implants for sites 26 and 27 were TS3BA surface, 5.0 mm in diameter and 10 mm in depth. For site number 26, the sinus floor was found to have a steep slope, with the lowest point measuring about 3.3 mm. Assuming a minimum height of 3 mm, we determined that initial drilling should start at 2 mm. For initial drilling with 2 mm depth, freehand surgery could be challenging. Using the OneCAS KIT, however, drilling could safely begin at 2 mm without issues. The highest point measured around 4.4 to 5 mm, and I anticipated that the maxillary sinus floor might not be penetrated immediately, so I planned accordingly. Now, let's discuss the drilling sequence for site 26. As mentioned earlier, assuming a safe alveolar bone height of 3 mm, the initial drill will be up to 2 mm with a 2.2 by 7 mm twist drill with a 5 mm stopper. After initiating drilling at 2 mm, we will gradually expand up to a final diameter of 3.8 mm as we plan to place a 5.0 mm implant. The drilling will proceed step by step to penetrate the sinus floor. Once the sinus floor is penetrated, a hydraulic sinus lift will be performed, followed by bone grafting. For the bone graft, we will use A-Oss Collagen before placing the implant. Now moving to site 27, the lowest point measures approximately 4.8 mm, so the initial drill will start at 3 mm. The posterior area has a relatively higher bone height, reaching over 7 mm. For a drilling sequence at number 27, Drilling will start at 3 millimeters since the residual alveolar bone is about 4 millimeters. Once the sinus floor is sufficiently penetrated, the sinus membrane will be elevated using hydraulic pressure, followed by bone grafting and implant placement. This is the immediate post-operative condition. The surgery was performed approximately 5.5 months after socket preservation at site number 26. Both implants are well placed, and bone grafting was performed on the sinus floor using A-Oss Collagen. For site number 26, you can see that the augmentation beneath the sinus cavity was performed using A-Oss Collagen for bone grafting. Similarly, in site number 27, bone grafting was carried out below the sinus floor. This is the condition 1.5 months after the surgery. 1.5 months on, site number 26 is healing well without any complications. Likewise, site number 27 is also healing without any issues. ER-type prosthesis has been placed. The anterior site in 21 was previously shown in a past online surgery session where the implant placement was demonstrated. You can see that the prosthesis has been placed at site in 26. The restoration was placed approximately 6 months after implant placement. The healing process has been smooth without any complications. The prosthesis for site number 27 has also been successfully placed. The current condition is approximately 10 months post-surgery. Socket preservation at site number 26 was performed about 1 year and 3 months ago, while the implants at sites number 26 and 27 were placed around 10 months ago. About 10 months after the surgery, you can see that the bone grafting performed via the crestal approach at site number 26 has healed well. The overall healing process has been progressing smoothly. The surgical video will now show the procedure. The OneGuide template has been positioned and properly adapted. Using a tissue punch, we will remove the overlying mucosa at sites 26 and 27. Next, we will trim the bone using a flattening drill. The same flattening drill will be used at site number 27, followed by a 2.2 by 7 mm twist drill with a 5 mm stopper, beginning at 2 mm. Freehand drilling at 2 mm can be challenging, but when using the OneCAS system, the initial drill starts at 2 mm. Then a 2.8 mm OneCAS drill, thus a 7 mm drill, and a 5 mm stopper are used, so it will be 2 mm deep. First, the 2 mm drilling is done, followed by the final drill of 3.8 mm in diameter and 7 mm in depth, and a 5 mm stopper, also drilling up to 2 mm with the final diameter. Once the implant drill hole is expanded, we will proceed with a 4 mm stopper, thus drilling up to 3 mm. We will advance by 1 mm each time to penetrate the sinus floor. Drilling will be performed up to 3 mm using a 4 mm stopper. As you can see, since the sinus floor has not been penetrated yet, the stopper is not in touch with the template. This is a 7 mm drill with a 3 mm stopper. That means we will proceed with drilling up to 4 millimeters. After drilling up to 4 millimeters, we will attach a 6 millimeter stopper to the 10 millimeter depth gauge to measure the 4 millimeter depth. The sinus floor has not yet been penetrated. Next, we will attach a 2 millimeter stopper and drill up to 5 millimeters. Complete penetration has not yet occurred. Therefore, we will proceed with drilling up to 6 millimeters using a 1 millimeter stopper. Drilling will be performed up to 6 millimeters with a drill of 3.8 millimeters in diameter and 7 millimeters in depth with a 1 millimeter stopper. After drilling up to 6 millimeters, it seems that there might be a slight penetration of the sinus floor. Since we have drilled up to 6 millimeters, now we are using a 4 millimeter stopper. It has not fully been penetrated, but there is partial penetration. Despite slight penetration, we will proceed with hydraulic sinus lifting for safety. Since complete sinus elevation has not been achieved with partial penetration, we will continue drilling up to 7 millimeters. We will drill up to 7 millimeters without a stopper. After reaching 7 millimeters, we will attach a 3 millimeter stopper. As you can see, the stopper is now touching the template, confirming that the sinus floor has been penetrated. We will proceed with another hydraulic sinus lift. Using a 3 cc syringe, we will repeatedly inject and aspirate little by little. Given that negative pressure is applied with blood regurgitation, we can confirm that the sinus membrane is being elevated without damage. The sinus membrane is being sufficiently elevated. This is A-Oss Collagen. After hydrating the A-Oss Collagen, we will trim it with a scalpel to make it slightly narrower, and then perform bone grafting inside the sinus. We will attach the bone carrier to the template. This is A-Oss Collagen. Using a bone condenser, we are performing bone graft into the sinus cavity. Next, a 5.0 millimeters by 10 millimeter implant will be placed. This is a TS3BA surface implant. After sufficient hydration, we will proceed with implant placement. Using the engine, insertion is about 70 to 80%, but it is slightly less than expected. The bone is dense, so we will use an implant driver to position the implant on its final location. The primary torque appears to be sufficient. A torque of over 30 Newton centimeter is being achieved. Assuming a 3 mm safe margin, we will use a 4 mm stopper and proceed with drilling up to 3 mm first. We will proceed with drilling up to 3 mm with a 2.2 mm diameter drill, and then use a 2.8 mm OneCAS drill with a 4 mm stopper. Since we have drilled all the way up to 5 mm, we will attach a 5 mm stopper to the depth gauge. The sinus floor has not yet been penetrated, so the stopper is not in contact with the template. We will now proceed with drilling up to 6 mm using a 1 mm stopper. Drilling has been done up to 6 mm, and we have attached a 4 mm stopper to the depth gauge to measure 6 mm depth. Complete contact has not yet occurred. We will now drill up to 7 mm without a stopper. It feels like the sinus floor is slightly being penetrated. A 3 mm stopper has now been attached to the depth gauge. This is to measure 7 mm depth. As you can see, the stopper and template are now in contact, confirming that the sinus floor has been penetrated. We will proceed with hydraulic sinus lifting. As blood gets regurgitated and negative pressure is generated, we can confirm that the sinus membrane is being elevated without damage. For site number 26, the stability is 77 and 77. It is relatively stable. For site in 27, the stability is 77 and 80. Since the residual alveolar bone at site in 27 was slightly higher, we will make a minor incision. Because there was very little bone on the palatal side, we will perform additional bone grafting. After making an incision, we will slightly elevate the mucoperiosteal flap on the palatal side. After the elevation, healing abutment is placed to prevent the graft materials from slipping into the implant. Healing abutment will be placed for number 27 as well. For site 26, where there was originally no bone on the palatal side, we will proceed with bone grafting like this. Bone grafting is being focused on the palatal area of site number 26. We will now proceed with suturing. This concludes the surgery. As you can see, the height of the residual alveolar bone was only about 3 millimeters. So if we were to start with initial drilling of 2 millimeters, freehand surgery can be challenging in securing correct positioning. By using the OneCAS system, however, we are able to successfully place the implant with a crestal approach, even when the residual alveolar bone is merely 3 millimeters. Since the palatal side of site 26 had insufficient bone, we performed additional bone grafting after implant placement for this case. Thank you for watching.